Hello, and welcome to another episode of the Care Coordination Minute. This is episode 8. I do want to take a second to tell all of you that if you haven't watched the first set of episodes all on CCM or chronic care management, I'm going to highly recommend that you do that because as we go forward in these episodes, I am going to compare a lot of the elements back to CCM. So if there's some elements there that in CCM that you don't understand, as I start to talk about them, they will be in previous episodes. So I just wanted to make sure everyone was aware of that. But you can always make a comment or send me an email, and I'm happy to answer your questions. So, with that, let's get into behavioral health integration. I want to talk a little bit about this. So, behavioral health integration or BHI, I want to first of all say it's not the same as IBH, integrated behavioral health. Integrated behavioral health has been around since the 1970s, quite frankly. And that is when, in your primary care practices, you integrate professionals who also can do mental health, such as psychiatric nurse practitioners, social workers, licensed clinical social workers, other types of therapists, those kinds of things. That model's been around a long time, although hasn't caught on and isn't in a lot of clinics, but it is out there. But in 2017, Medicare decided that they would pay for behavioral health as a care management model. And with all the words in the dictionary, for whatever reason, they use the same words and just put them in a different order. Behavioral health integration. They do not mean the same thing. So behavioral health integration is typically done by primary care, but it can be done by any practitioner that is seeing a patient that for behavioral health. So again, it does need to be a physician, so MD or DO, a nurse practitioner, and that can be a family nurse practitioner, geriatric nurse practitioner, does not have to be a psychiatric nurse practitioner, but could. Um, a PA, a the other area that we're going to be talking about a little bit as we go forward is a licensed clinical social worker or a clinical psychologist that are billing Medicare, as well as clinical nurse specialists and midwives. So that's the group of people who are allowed to bill for these type of services. And I'm going to do a lot more minutes as we go forward so that you'll understand them. But typically, the thought behind it was that it was primary care. So you'll see BHI is initiated by the primary care provider. But again, it doesn't have to be primary care. So there is an initial assessment. We're going to go through each one of these in their own minute as we go forward, and it's going to be modeled just after how I did CCM. It does require that you use a validated rating scales, and we'll talk about those in a future episode, as well as the care planning. The care planning is exactly the same type of care planning, although for different diagnoses, of course, that we do for CCM. And this is something that can be built with CCM. You can have a patient in CCM, for example, who has diabetes and hypertension, and they also have depression. They can be managed in both of these programs. You can combine that care plan just so long as the care plan is covering all those diagnoses. So that's really an important piece. Now let's talk about what does it take to be qualified for BHI from a patient standpoint. Typically, Medicare is where we're talking. However, I'm excited to say that there are other insurances who are covering BHI. So that's a positive. And we're finding more and more of it in the mental health world of Medicaid. So that's also pretty exciting. Okay, so what does it take? It's any mental, behavioral, or psychiatric condition being treated by the billing practitioner. So whoever is treating them, it doesn't have to be primary care, but whoever is treating them to kind of go through that piece. And it includes substance use disorder. And that's a really important piece because back in the day, we used to bring all this together. And then we had this revelation that was not very smart, but we separated those. So we had mental health being taken care of here, substance use disorders being taken care of here. And a lot of places did not take care of both. Well, we realized that, of course, substance use disorders actually, lots of times that comes out of the fact that people are trying to medicate themselves. So these are combined again. So that's a huge, huge, huge win. And here's the thing, there's no time limit, none of that. It's just in the clinical judgment of the billing provider, the patient would benefit from these services. So, unlike CCM, where we talk about the chronic conditions have to last at least 12 months and blah, 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 and all of this stuff, that does not apply here. It's if the provider thinks you would do well. It would help you to be part of a behavioral health integration program. That's all it takes. It does still have patient consent, and the documentation is 20 minutes. So that's the quick overview of BHI. Please stick with me because we are going to have many more of these as time goes on, as we go through each element in a hopefully a short and condensed way. So with that, have a great day. If you need to reach out to me, those are all the places you can find me. Thanks so much. Bye-bye.